Hello everyone and welcome to another resume lecture. After we have explained the C-segment elevation, T-segment depression and pathological Q waves, we are coming to the interesting topic and common situation in our clinical practice, T-wave inversion. We are going to learn today the various patterns and causes of T-wave inversion, plus the clinical significance of T-wave inversion in different clinical situations. First of all, we should know that subtle change in T-wave are often the early sign of MI, and nearly in about 20-30% of patients presenting with MI, T-wave changes may be the only ECG sign. Of course, we know that normal ECG doesn't exclude MI. It may happen in myocardial infarction as a non-STEMI, and so what about the presence of T-wave inversion? Of course, it increases the possibility for myocardial ischemia. And to decide that the T-wave is abnormal, of course, we should remind ourselves what is the normal T-wave. Regarding amplitude, of course, we know that it is measured from the baseline to the peak of the T-wave, and it is usually less than 2/3 of the complex amplitude and more than 10%, and it decreases slightly with age. Of course, in limb leads, normal T-wave is usually less than 5 mm. In precordial lead, usually it is less than 10 mm, and it is maximal in V2, 3, and V4, which are the mid-precordial leads. Regarding the morphology, of course, we remember T-wave is asymmetrical morphology. Slow ascending slope, rounded peak, and rapid descending slope. And even when it is inverted in the lead showing negative complex, it is always asymmetrical, and this asymmetry is more pronounced with bradycardic rhythm. Regarding the axis of the T-waves in limb leads, we know that the polarity of the T-waves follows the complex, and so it is always positive in lead 1, 2, plus minus in AVL, and it is negative in AVR, and often it is positive in lead 3 and AVF, but it can be negative or biphasic in some normal conditions. In precordial lead, T-wave is often negative in V1, and in children, the transition zone is usually in V3 to V4, so normally in children we can see negative T-waves up to V3, and then the transition zone of the T-wave travels to the right with age, and so in adults the transition zone is usually between V1 and V2. So, of course, negative T-wave after V1 is very rare beyond the age of 15 years, but sometimes negative T-waves may be observed in V2, 3, especially in obese patients, and if the T-waves is present in adults beyond V1, it is called juvenile T-wave pattern, but in most of the cases you would see just normal T-wave or negative T-wave in V1 and then positive in the rest of the precordial leads. So give me the rules for normal T-wave. QRS and T-waves tend to have the same direction in the limb leads. T-wave must be upright in lead 1, 2, and from V2 to V6. T-wave must be negative in AVR, and T-wave may start negative in V1 and then it turn positive in the rest of the precordial leads. We remember this diagram, of course, for the abnormal T-wave. We have the T-wave inversion, biphasic T-wave, and the hyperacute T-wave. We mentioned, of course, that the hyperacute T-waves reminds us of the STEMI, and sometimes it may even precede the ST segment elevation, and we have discussed this in a separate lecture. We have the asymmetrical T-wave inversion, which usually reminds us of the strain pattern on the secondary repolarization abnormalities, and always we think of the symmetrical T-wave inversion and biphasic T-wave as very suggestive for myocardial ischemia. So for example, in this ECG, we can see here precordial T waves that are exceeding more than 2/3 of the complex amplitude. So here we are speaking about hyperacute T wave and starting to have ST segment elevation nearly in V2 and V3. And sometimes the hyperacute T wave may precede the ST segment elevation. That's why we should pay attention to the hyperacute T waves. And we remember, of course, the ECG evolution in STEMI, that of course the ECG start as being normal, and then hyperacute T wave may appear with the ST segment elevation or even before it, and then the patient has frank ST elevation together with the hyperacute T wave. If the patient had successful reperfusion, so the patient may have improvement or resolution of the ST segment and reduction in the amplitude of T wave, and then the patient may have T-wave inversion at last after the successful reperfusion, and then the ECG may return weeks later to the normal baseline. But with failed reperfusion, in this case, the patient would have pathological T-waves and the ST segment elevation may be the same and starting to have biphasic T-wave. And then the ST segments start to improve, but with persistent pathological Q waves due to failed reperfusion and irreversible damage, and the patient would have T-wave inversion together with the pathological Q waves, weeks to months later, the T wave may return to become upright, but with persistent pathological Q waves due to the irreversible damage in the affected territory. So remember, the T waves start initially in STEMI to be hyperacute, then they turn to be biphasic and then inverted with the evolution of infarction, and they either return to the normal baseline condition or remain inverted according to whether successful or failed reperfusion is performed. So apart from the T wave changes in STEMI, we have very important disease category that is showing T wave changes, which is the non-ST elevation acute coronary syndrome, showing T wave inversion as one of the most famous ECG signs after ST segment depression, as we mentioned before. We remember before that in the 2020 ESC guidelines for non-ST elevation acute coronary syndrome, they have put criteria for isolated T wave inversion, more than 1 mm inversion in 5 or more leads, considering lead 1, 2, AVL, and from V2 to V6. And of course, as we mentioned before, that normal T wave is asymmetrical, as we mentioned in the normal T wave rules. And so, the T wave inversion can be asymmetrical in most of the cases related to normal or negative complex, or related to asymmetrical T wave inversion in secondary repolarization abnormality. But when it becomes symmetrical, of course, it is very suggestive for myocardial ischemia, and we consider the T wave inversion to be deep if more than 5 mm depth. So remember, symmetrical T wave inversion are almost a sign of myocardial ischemia in most of the clinical situations. So let's see this ECG example here. We can see here symmetrical T wave inversion from V2 till V6, and of course they are very suggestive of myocardial ischemia based on the symmetrical morphology, as we have an equal slope for the descending and ascending limbs. And here another example about symmetrical T wave inversion, and they are starting to become deep as they are approaching 5 mm depth. While here we can see asymmetrical T wave inversion from V2 to V6, suggestive of secondary repolarization abnormalities. And here another example in which we can see asymmetrical T wave inversion from V2 to V6, so most probably they are suggestive of secondary repolarization abnormalities rather than myocardial ischemia. We remember another morphology, which is a biphasic T wave, as it can start to be positive and then turns negative, or initially negative and then turns positive, so both morphologies are famous. In this ECG example, we can see biphasic T waves from V2 to V4, so mostly it signifies ongoing myocardial ischemia. And we remember the famous Wellens syndrome, which usually show isoelectric or minimally elevated ST segment, but it shows whether biphasic T wave, which usually appear in V2 and V3 in 25% of cases, it's usually called Wellens syndrome type A, or we can see deep symmetrical T wave inversion V2 and V3, which occur in 75% of cases, and we call it Wellens syndrome type B, and these change of course may extend to the rest of the precordial leads. And we mentioned before that Wellens syndrome signify proximal LED occlusion or severe stenosis with about 99% correlation in statistics. So for example, in this ECG, we can see there is biphasic T wave from V1 to V3 with symmetrical T wave inversion in V4 and 5, indicating Wellens syndrome type A. Whereas in this ECG example, the T waves are deep symmetrical from V2 to V5, indicating Wellens syndrome type B. And here another example in which we can see deep symmetrical T wave inversion from V2 to V5, indicating Wellens syndrome type B as well, which occurs in the majority of cases of Wellens syndrome. And we should remember, Wellens syndrome can occur in non-ST elevation acute coronary syndrome and also in chronic coronary syndrome patients presenting with effort angina. And both cases will need to proceed to invasive coronary angiography plus minus revascularization of the LED rather than non-invasive imaging. So now we know that T wave inversion in precordial leads can be a sign of ongoing myocardial ischemia. So the question, can upright T waves be a sign per se of ongoing myocardial ischemia? We remember, of course, this lecture, it was pseudo-normalization of T waves. Sometimes in patients who are already ischemic or having chronic ischemic injury, they would have resting T wave inversion while they are off chest pain. And when they develop anginal pain, they have upright T wave in the second ECG. So it is like a superimposition of acute myocardial ischemia over chronic ischemic injury. It may be an early sign preceding ST elevation or coronary vasospasm or part of non-ST elevation. So for example, in this patient, he was having T wave inversion in infralateral leads, and when he developed anginal pain, he had upright T wave, and this we call pseudo-normalization pattern. And we mentioned why we called it pseudo, because the T waves return to become normal, but actually it signifies a pathology rather than normalization. And so chest pain with pseudo-normalized T waves in resting ECG, it signifies ongoing myocardial ischemia as pseudo-normalization pattern of the T waves. Another issue regarding T wave inversion. T wave inversion can be dynamic or static. Dynamic, like there is dynamic change in T wave axis and or morphology in serial ECGs, like in ongoing ischemia in case of STEMI or non-STEMI, or it may be static with the same axis and morphology in serial ECGs, like following MI with failed reperfusion accompanying pathological T waves, and the patient mostly is off chest pain. And without any doubt, dynamic T wave change is a high-risk sign for ongoing myocardial ischemia, while static T wave changes, which is the same and the patient is off chest pain, is not clinically significant as a dynamic change. And another question regarding T wave inversion. Can the T wave inversion be dynamic through a single ECG strip rather than serial ECGs? Yes, of course. It is slightly rare phenomenon, but it is of course very characteristic and unique, in which there is alternating peak-to-peak variation in the T wave timing, axis, amplitudes, and or in the morphology like we see in this strip. And this we call T wave alternance, which usually occurs in patients with long QT syndrome and is considered a high risk of sudden cardiac death. So this phenomenon we don't see in myocardial ischemia, we can see in patients with long QT syndrome. Now we have finished the first part of our lecture about T wave inversion in myocardial ischemia. Now to the second interesting part, which we have dedicated a lecture in order to discuss it. What can cause T wave inversion apart from myocardial ischemia? We have many pathologies like hypokalemia, secondary repolarization abnormalities or the strain pattern, pulmonary embolism, which is usually forgotten as a cause of T wave inversion, raised intracranial pressure, memory T waves, and the juvenile T wave pattern, which is a normal variant. Let's start with the potassium disorders. In hyperkalemia, what do we expect to find? In hyper, we expect hyperacute T wave, long PR interval, absent P waves, wide complex T elevation, and in extreme condition sine wave pattern. And these conditions can be a result of the severe hyperkalemia resulting in mortality. So in hyperkalemia, we can see hyperacute narrow and pointed T waves with ST elevation. So this is for hyperkalemia. What about hypokalemia? We mentioned before that it can cause ST depression together with T wave inversion and long QT interval, as hypokalemia, hypocalcemia, hypomagnesemia are famous cause of QT interval prolongation. So hypokalemia can cause ST depression and T wave inversion. And we need to emphasize an important tip in clinical practice. We remember the biphasic T waves, that it can be initially positive and then negative, or initially negative then positive, and usually suggest myocardial ischemia. But here it is a time to emphasize that usually when it starts to be positive and then negative, it's more suggestive of myocardial ischemia, and when it is the opposite, it is more suggestive of hypokalemia. Although sometimes the reverse may happen, but I'm speaking about the common. So for example, here in this ECG, we can see biphasic T waves here that are starting negatives and positive. May suggest Wellens syndrome type A, but it may suggest hypokalemia, especially that the patient is having long QT intervals. You need to check the potassium disorder before assuming that it is caused by ongoing myocardial ischemia. We remember, of course, this morphology that we have explained before, that we have the complex representing ventricular repolarization and T wave plus the ST segment represent ventricular repolarization. So ST segment and T wave changes are considered to be repolarization abnormalities, and this brings us to the second cause of T wave inversion apart from myocardial ischemia, which is the secondary repolarization abnormalities previously called strain pattern that usually accompany LVH or RVH, leading to T wave inversion in resting ECG, but may also occur in bundle branch block and the structural disease of arrhythmogenic RV cardiomyopathy, and usually, of course, they are asymmetrical rather than symmetrical. So, for example, in LVH, they usually occur in the left precordial leads, V5 and V6 plus minus lateral leads 1 and AVL, whereas in RVH, they usually occur in V1, V2, 3 plus minus V4 and the inferior leads, and of course, it makes sense according to the site of the hypertrophy. So, for example, in this ECG, we can see here the voltage criteria of the LVH represented by the skull line index plus asymmetrical T wave inversion and ST depression in the lateral lead due to secondary repolarization abnormality to LVH. Here is another example in which there is a patient having hypertrophic cardiomyopathy and he is having asymmetrical T wave inversion in the infralateral leads. So sometimes the secondary repolarization abnormality in LVH may extend to the inferior leads. And here we are having another extreme condition of a patient have apical cardiomyopathy or called Yamaguchi disease, in which he is having deep asymmetrical T wave inversion, but they are asymmetrical in V4, 5, and 6, suggestive of apical hypertrophic cardiomyopathy, extending as well to lead 1, AVL, and also to lead 2 and AVF. Here another example of a patient is having RVH as represented by the tall R wave in V1 with secondary repolarization abnormalities in the right precordial leads plus the inferior leads together with the ST segment depression. Of course, they may occur as well in left bundle and right bundle occurring in the corresponding precordial leads. Like here the patient is having left bundle branch block, so he's having T wave inversion, ST segment depression in V5, V6, which are the left precordial leads. Whereas here in right bundle branch block, the patient is having resting T wave inversion in V1, 2, and V3 right precordial leads, so it makes sense. Here is another ECG example of a patient having arrhythmogenic RV cardiomyopathy as represented by the epsilon wave, as the patient is having slurring positive deflection at the end of the complex and the start of ST segment in the right precordial leads plus the inferior leads, and also T wave inversion in the same corresponding leads, which is very famous ECG pattern with this disease pathology that usually affects the RV, but in extreme condition it may affect the left ventricle as well. And we mentioned before that one of the criteria for diagnosis of arrhythmogenic RV cardiomyopathy are the ECG repolarization abnormalities, and we are going to have a dedicated lecture for this disease per se. Paced rhythm as well may cause secondary repolarization abnormalities, as usually in the RV pacing it causes left bundle branch block. So it may cause secondary repolarization abnormalities in the lateral leads like 1 AVL, V5, V6. Sometimes they may appear in the inferior leads. So it is not strange to see asymmetrical T wave inversion in patients with ventricular based rhythm. Then we are going to move to another disease and different pathology, which is a pulmonary embolism. Of course, one of the high-risk signs in ECG that with the RV strains that sometimes occur with the pressure load on the right ventricle results in T wave inversion in the right precordial leads plus minus the inferior leads. So as an RV strain, it is the same pattern that usually occurs in patients with intermediate risk or high risk pulmonary embolism, indicating RV pressure overload and may indicate, together with the clinical presentation, the need for thrombolytic therapy. So for example, here in this patient with pulmonary embolism, he is having strain pattern in the right precordial leads, and also he's having the famous ECG sign of S1Q3T3, as he is having S wave in lead 1, Q wave in lead 3, together with T wave inversion in lead 3. So pulmonary embolism is one of the famous causes of T wave inversion. That's why we need to focus on the clinical presentation of the patient before assuming it is myocardial ischemia. Raised intracranial pressure is one of the famous causes in books and in our clinical practice of the T wave inversion. Even it is one of the causes of deep symmetrical T wave inversion together with a myocardial ischemia, raising the suspicion of myocardial ischemia as the first possibility, of course, in a patient having these ECG features, although the patient is having a completely different clinical presentation, and usually it favors the presence of cerebrovascular accident, either stroke or intracranial hemorrhage, rather than acute coronary syndrome, and we usually call this pattern cerebral T waves. So here we are not having a patient with chest pain, we are having a patient with lateralization signs or is having disturbed conscious level, and he is having these ECG features. So here's this patient with subarachnoid hemorrhage. He is having deep symmetrical T wave inversion starting in V2 and becoming deep in V3, 4, 5, and 6. And this patient, of course, is not having chest pain, so we should not suspect myocardial ischemia. That's why clinical presentation is crucial. And here the patient is having deep symmetrical T wave inversion due to subarachnoid hemorrhage. That's why subarachnoid hemorrhage is a very famous cerebrovascular accident that caused T wave inversion together with the cerebrovascular strokes. Memory T waves is another famous cause of T wave inversion, in which the patient is having persistent T wave changes that he was having when he had a period of YQRS rhythm due to the abnormal ventricular activation. And once the normal activation is restored, the patient is having the same T wave changes, like following a period of intermittent ventricular pacing, intermittent pre-excitation, transient left bundle or right bundle branch block, or following paroxysmal VT. So for example, this patient is having symmetrical T wave inversion in lead 3 and lead AVF. When I see this ECG, I may suspect myocardial ischemia, but when I see a previous ECG for this patient, he's the same patient, he was having manifest pre-excitation, Wolff-Parkinson-White syndrome, and so he had successful ablation of the accessory pathway, resulting in the memory T waves. And if we focus here, we can see that the patient was having negative complex in lead 3 and AVF during manifest pre-excitation, and then after restoration of normal sinus rhythm and normal conduction in the AV nodes, he's having negative memory T waves as he remembers the negative complex in lead 3 and AVF. So memory T waves here are following the direction of the negative complex during Wolff-Parkinson-White pattern. Here's another example in which the patient was having ventricular pacing and capturing, and after cessation of the ventricular pacing, the patient is still having T wave inversion in the infralateral leads. So the memory T waves here remember the periods of ventricular pacing, and after its cessation, they are still present. And if we compared both ECGs together, we can see that the complex were negative in the infralateral leads, and then the memory T waves are negative in the same leads. So memory T waves follow the direction of the negative complex during the period of pacing. So we remember that memory T waves occur when normal activation of the ventricle is restored. So the T wave remembers the direction of the YQRS complex, resulting in positive T waves in leads with positive Y complex, whereas negative T waves in lead with negative Y complex, and they can persist up to weeks after normal ventricular conduction is restored. And if we ask ourselves why is it important to diagnose them specifically, of course it is important to avoid unnecessary hospitalization and the cardiac catheterization, as it is considered just a benign finding that doesn't raise suspicion for myocardial ischemia, and so it reduces the burden of unnecessary admission to the CCU and unnecessary cardiac catheterization. Then we move to the diagnosis of exclusion, which is a persistent juvenile T wave pattern. The patient here is adult, older than 15 years, and is having still T wave inversion in right precordial lead, but they are asymmetrical, shallow, and usually affect V1 to V3. And they are commonly seen in young patients, Afro-American, and more in females than males. So if this patient is completely asymptomatic, I should not be aware or afraid that this patient is having myocardial ischemia. So for example, here in this example, the patient is having shallow asymmetrical T wave inversion in right precordial leads, so it is juvenile T wave patterns that may persist till adulthood. And although we call it persistent, actually it is not always persistent, as sometimes it may be absent in previous ECG and then appear, or vice versa. So here is a problem that the patient would have dynamic T wave inversion, but he is completely asymptomatic through his history. So one of the possibilities that is a diagnosis of exclusion is persistent juvenile T wave pattern. So now, after we mentioned many causes for T wave inversion, we can summarize them. as myocardial ischemia is the first possibility, whether it is STEMI, non-ST, or chronic coronary syndrome, but also we have hypokalemia, secondary repolarization abnormalities, pulmonary embolism, memory T wave, cerebral T wave, and persistent juvenile T wave pattern. So of course, clinical presentation is crucial to decide what is the cause, but I need to be able to differentiate in the clinical practice. How can I differentiate? So let's come to the summary of this lecture. First thing, clinical presentation is essential because not only myocardial ischemia is a cause, it can be acute coronary syndrome, of course, it can be pulmonary embolism, and it can be cerebrovascular accident. So you need to check the clinical presentation before assuming it is just ongoing myocardial ischemia and you are misdiagnosing the patient. Then we need to check for presence or absence of ST elevation, as it may be part of STEMI. So I need to check the 12 leads for any evidence of ST segment elevation with the T wave inversion. Then the morphology is very important, whether it is asymmetrical, symmetrical, or biphasic. And we remember, of course, that symmetrical T wave inversion and biphasic are more suggestive of myocardial ischemia, whereas asymmetrical is more suggestive of secondary repolarization abnormalities. Then the magnitude, of course, if it is deep, more than 5 mm, it is more suggestive of myocardial ischemia, as in Wellens syndrome type B. And finally, the associated ECG signs. For example, the patient is having pathological Q waves or ST depression, so I would assume it is non-ST elevation acute coronary syndrome. The patient is having voltage criteria of LVH or RVH or left or right bundle, so I would assume it is secondary repolarization abnormalities. The patient is having long QT interval and or prominent U wave, I would search for hypokalemia. Or the patient is having previous ECG showing Wolff-Parkinson-White pattern, ventricular pacing, VT, or intermittent bundle branch block, I would assume it is memory T waves. And remember, persistent juvenile T wave pattern may be a possibility, but it should be diagnosed only by exclusion. I would not assume it as the first possibility. I need to exclude the higher risk conditions before assuming it is just a benign finding of persistent juvenile T wave pattern. So we have 5 points to check for the T wave inversion: clinical presentation first, presence or absence of ST elevation, morphology, magnitude, and associated ECG signs. And so as a summary, these are the causes of the T wave inversion, and the first thing to check the clinical presentation to be able to differentiate. So at the end of this interesting long resume lecture, we understood today the various causes and patterns of T wave inversion, and we understood the clinical significance of T wave inversion in different clinical situations besides the myocardial ischemia. And our take-home message today: symmetrical T wave inversion should always raise suspicion of myocardial ischemia, although they are not the only cause, but it is the first possibility. And secondary repolarization abnormality are a very common cause of T wave inversion in our practice that should be differentiated from myocardial ischemia. And of course, clinical presentation is very, very important before you decide the cause. Thank you very much for your watching.